Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we're going to talk about ICD-10 documentation for dermatology. There are some changes you will need to make in your documentation to support ICD-10, but there remain instances of documentation that can remain the same. I know you're itching to learn more, so let's get started. I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives. Link the cause and effect of each condition and be specific about aspects of a disease and each anatomical site. A little more on each of these. Differentiate in your notes whether or not a condition is acute or chronic, bullous or non-bullous, or generalized or localized, for example, when appropriate. For example, document chronic radiodermatitis instead of radiodermatitis. Use due to or secondary to indicate cause and effect and to record all conditions the patient may have, such as allergic contact dermatitis due to the metal nickel. Be specific about documenting aspects of the disease processes such as Stevens-Johnson syndrome, involving 35% of the body surface. Precisely designate anatomical sites such as stage 3 pressure ulcer of the left lower back or cellulitis of the right axilla. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care. Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes, and it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases and procedures that have new documentation requirements in ICD-10. In ICD-10, there is a feature called laterality for right, left, and bilateral, which is found in many diagnosis and procedure codes involving paired organs or those codes specific to one side of the body versus the other. For example, lymphangitis of right or left lower extremity. ICD-9 had a limited number of these. ICD-10 has many more. This feature of ICD-10 by itself is responsible for a substantial increase in the number of codes which you have probably heard so much about. Since you usually include this information in your patient care notes when applicable, additional documentation will typically not be needed. So FYI, if you happen to omit laterality when needed, it may result in a query. Suffice it to say, laterality is included when appropriate for some conditions you may treat, for example, pressure ulcer of the left ankle. So do a quick double check of your notes to be sure you included it before signing off. We'll try not to belabor this point in the upcoming slides. The only thing new in ICD-10 for the diagnosis of cutaneous abscess, carbuncle, and furuncle is that they have been slightly reorganized, if you will, from ICD-9. Individual codes are provided for each condition by anatomical site. On screen, you will see the individual codes for an abscess, furuncle, and carbuncle of the neck. Documentation of the infecting organism remains unchanged from ICD-9. You should continue to document the organism if known, such as abscess of right ankle due to Staph aureus. In ICD-9, cellulitis and acute lymphangitis share the same code. ICD-10 provides separate codes for each condition. One thing you should be aware of is that when a patient has both a cellulitis and acute lymphangitis, coding convention directs that only the code for cellulitis is assigned. Lastly, you should document the infecting organism if it is known or suspected. As you are probably aware, ICD-9 provided two rather generic codes to classify acne. ICD-10 provides a few more specific codes. Take a look on screen to see the new code options for acne. Capturing some additional specificity about acne may help the medical community as they work to measure treatment outcomes for this condition. The terms dermatitis and eczema are used interchangeably in ICD-10, much the same as they were in ICD-9. You will find that ICD-10 provides codes for most of the same types of dermatitis and eczema that you were familiar with in ICD-9. What's different in ICD-10 is that contact dermatitis is further specified as being due to an allergen or irritant. ICD-10 provides combination codes to identify the allergic or irritant nature as well as the cause or trigger. An example is allergic contact dermatitis due to cosmetics or irritant contact dermatitis due to detergent. So please make sure to document the nature of the contact dermatitis as well as the cause or etiology, since this will likely impact subsequent treatment. If a drug or medication is causing an outbreak of dermatitis, it is usually clear from your notes whether the drug was in contact with the skin or taken internally, but please make sure so that correct code assignment can occur. Additionally, ICD-10 classifies the skin eruption associated with a drug-induced dermatitis as generalized or localized, which needs to be documented in your note as well. As I mentioned earlier, ICD-10 has greater specificity for anatomical site, which is also seen in the ICD-10 categories for neoplasms of the skin and requires documentation of laterality of paired organs and structures such as ears, eyelids, and limbs, to name a few. Be sure your documentation is as specific as possible when identifying anatomic site, such as basal cell carcinoma of the skin of the left upper arm, or melanocytic nevi of the right eyelid. In ICD-10, there is a new code category for melanoma in situ. In ICD-9, there was no way to distinguish a melanoma in situ from a malignant melanoma, so that is good news. Unchanged from ICD-9 is the classification of malignancies as primary or secondary, which is a particularly problematic area of documentation for coders. Often, primary or secondary is not specified, and in the case of secondary malignancies, whether the primary site is still present. A statement of history of can be ambiguous and may prompt a query. For example, appropriate documentation of a malignancy would be history of basal cell carcinoma of skin of right wrist. Patient underwent a Mohs procedure 1 year ago and there is no evidence of recurrence. This documentation clearly identifies the primary site as no longer present, which is an important factor considered during code assignment. In ICD-10, pemphigoid, like some of the other skin conditions, expands from one code in ICD-9 to several more specific codes. Take a look at the new code options on screen. If pemphigoid is drug-induced, make sure to include the offending drug in your notes. There are two new changes associated with pressure ulcers in ICD-10. The first is that the anatomical site and the stage of the pressure ulcer are combined into a single code. This required two codes in ICD-9. The second is that laterality has been incorporated into the applicable pressure ulcer codes, such as pressure ulcer of right elbow or left upper back. So it is important to document the specific anatomic sites and laterality when applicable for pressure ulcers. As you may be aware at this point, coding professionals can use nursing or physical therapy documentation to obtain the stage of the pressure ulcer, but you must document the diagnosis of pressure ulcer in your note in order for it to be coded. Also, when documenting in the hospital record, it continues to be important to indicate if the pressure ulcer was present at the time of the patient's admission. As in ICD-9, ICD-10 classifies non-pressure chronic skin ulcers by anatomic location. What's new in ICD-10 is the ability to report the degree of tissue breakdown present. It is important for you to indicate in your notes whether the breakdown is limited to the skin, or if the fat layer is exposed, the muscle is necrosed, or bone necrosis is present. This may impact subsequent documentation as well as treatment of the ulcer if excisional debridement is required. Additionally, you should link the etiology of the non-pressure ulcer in your documentation if it is known. For example, it would be appropriate to document diabetic ulcer of left, fourth, and fifth toes with bone necrosis, or venous stasis ulcer of the medial aspect of the right ankle. ICD-10 provides additional specificity for psoriasis and parapsoriasis. If you can describe psoriasis more specifically as psoriasis vulgaris, generalized pustular, acrodermatitis continua, guttate, or pustulosis palmaris et plantaris, rather than simply psoriasis, it will result in codes that give a more accurate picture of the type of psoriasis you are treating. Additionally, ICD-10 provides the ability to capture more information about psoriatic arthritis. Codes are provided for psoriatic arthritis mutilans, spondylitis, and juvenile arthritis, as well as distal interphalangeal arthropathy. For your patients with parapsoriasis, it is important to specify if the disease is small or large plaque, retiform type, or psoriasis lichenoides, acuta or chronica, since ICD-10 allows for more specificity of this disease process as well. You may see patients in your dermatology practice with one or more of the following diseases: sarcoidosis, scleroderma, or systemic lupus erythematosus. One characteristic that these diverse conditions have in common is that they either primarily or secondarily affect the skin. Another component they have in common is that ICD-10 provides combination codes to identify the disease and any target organ involvement. This is good news because only one code will be required to report the condition and target organ involvement, if any, instead of the minimum of 2 codes that were required in ICD-9. All you will have to do is to make sure to link the disease and any target organ involvement in your notes. As physicians are increasingly held accountable for patient outcomes, there is considerable concern regarding how to classify the patient who fails to follow a recommended regimen of care and gets sicker as a result. Under ICD-9, there is only one generic code for such a patient that says non-compliance, with no additional detail as to why the patient didn't follow your instructions. But in ICD-10, there are several codes to describe why a patient is non-compliant in taking drugs prescribed by you. The new clinical terminology is drug underdosing. Underdosing identifies situations in which your patient has taken less of a medication than prescribed by you, either unintentionally or intentionally. Document in your notes why the patient isn't taking the correct amount of their medication and the associated condition. For example, patient was seen in the office today with severe flare-up of her psoriasis. patient discontinued her adalimumab because she could not afford the cost of the medication. ICD-10 requires more detailed descriptions in your documentation of anatomical site, laterality, and aspects of a disease, injury, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patient's severity of illness and risk of mortality and the services rendered. This in turn will result in accurate public reporting on quality and outcomes. Thanks for joining me. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's clinical documentation improvement specialist should be your first stop. The coding staff in your Health Information Management Department is a valuable resource as well. Have a great day.